Welcome everyone to this morning's session, the role of interoperability during a pandemic. We are so pleased to have our gold level and pub crawl sponsor INTERFACEWARE presenting, and our speaker is Paul Lee, who is the solutions architect at INTERFACEWARE. He has been with INTERFACEWARE for about 3 years and has handled many implementations, and we're very excited to hear what he has to share with us this morning. So I will turn it over to Paul Lee.
Excellent. Thank you, Pat, for that introduction. So first and foremost, I'd like to thank everyone for joining this presentation. I imagine by now many of you have sat through several Zoom presentations, so I appreciate everyone for making the time for this one. As we all know, in past years, these working group meetings have been in person, but due to obvious circumstances, here we are today virtually. And to start off, I'd like to do just a quick introduction about myself, both myself and my colleague, Prashanth. So as Pat had mentioned earlier, my name is Paul Lee. I work at INTERFACEWARE as a solutions architect on the client solutions team. I've been working with INTERFACEWARE for over 3 years now, and I've worked with many of our customers implementing integration solutions and solving their integration needs. And joining me today for this presentation is also my colleague, Prashanth. Prashanth, could you please introduce yourself?
Thank you, Paul. My name is Prashanth. I've been with INTERFACEWARE for just a few months now. It's a wonderful company and very excited to be this year's Gold and Pub Crawl sponsor for HL7. Later on, Paul is going to talk about a contest. We wanted to make it very engaging and interesting for everyone here. So Paul will be disclosing some great details for you afterwards. So thank you.
Awesome. So as you can see on the slide here, our presentation will be on the role of interoperability during a pandemic. The focus will be primarily on what we saw from our perspective as an integration company, as well as some of the important lessons that we had learned. So to start off, I'd like to go through a quick outline of what we're going to discuss in this presentation. To start off, we'll do a quick introduction on ourselves, not Prashanth and I, but on INTERFACEWARE, who we are and what we do. I'll talk about our role, what our role was during the pandemic, what we saw, again, from our perspective as an integration company, which would then lead to some use cases or success stories that we had seen during this time. And then I'll also talk about our role going forward in this pandemic, not just our role as a company, but also our role, including everyone within the HL7 community. And then I'll wrap up with a conclusion tying this all together. As Prashanth had mentioned, we also have a small contest that we have running for those who stick around to the end. There's an Amazon gift card in it for anyone who wins. And then finally, we'll open it up for a Q&A, which Prashanth will help to facilitate. So to start off, we're going to go over a quick primer about INTERFACEWARE, who we are and what we do. We are an integration company with over 20 years of experience in the healthcare IT industry. Our primary claim to fame, so to speak, is that we developed the Iguana middleware integration engine. And as Pat also mentioned, we are also a sponsor of HL7 International. In previous years when we had meetings that were in person, you might have noticed on the lanyards that there were the lanyards that were given out for the badges. They might have had some form of our branding on them, which might have looked something like this. But unfortunately, this year, there's no lanyards. With regard to what we do, we primarily work with healthcare providers and software vendors. The healthcare providers that we work with, they range from small clinics and hospitals to large hospitals and research institutions. And the vendors, the software vendors, they come in all shapes and sizes. In general, we provide rapid, reliable, and scalable interoperability solutions. And it also goes without saying that we do this as securely as possible as well. But really, in general, the gist of it is that our bread and butter is being able to efficiently move data from point A to point B, while also normalizing that data within the process. I personally like to think of Iguana as kind of like a data blender, kind of like a Vitamix. If you've ever had a Vitamix blender, you can put like strawberries, bananas, even kale, and then it'll make a very nice smoothie. In the same way, Iguana is kind of like a data blender. You can add HL7, FHIR, JSON, XML, even X12, which is my least favorite format to work with. And it's going to create a very nice data smoothie. That's kind of like how I like to think of Iguana. And as you can see from the previous slide, that Iguana, being an integration engine, has a very unique position in many healthcare organizations. It essentially sits in the middle of everything. And so during the height of the pandemic, Iguana played a crucial role for a lot of our customers in facilitating interoperability. So this basically meant that Iguana played a role in moving data so that providers and researchers were able to have access to crucial data whenever they needed it.
You will be joined in talk mode. To mute or unmute your line, press *6. The conference is being recorded. If you object, you may disconnect now.
And during this time, we noticed that there were some common challenges that many of our customers were facing, again, namely around interoperability. A lot of these challenges that we saw could really be broken down into two categories.
If we can kindly ask people to mute their Zoom calls, that would really help us out. There's some Thank you.
Awesome, thank you. So again, as I was saying, there were two challenges that we saw, or two main categories of challenges that we saw that a lot of our customers were facing. The first challenge was that existing interfaces need to be quickly updated. So for example, any existing code mapping sets had to be updated to include COVID-19 related data or COVID-19 related mappings, for example. And the second category was that new workflows had to be quickly implemented. So for example, new order and results interfaces had to be developed for COVID-19 testing, for example. And these are both very general challenges, and we're going to go into some more specific examples later on. But in a way, that kind of just, it kind of highlights that this pandemic had affected a wide range of systems, and a wide range of problems had arose because of the situation. So with all that being said, how does Iguana fit into all of this? And again, Iguana, being an integration engine, sits in the middle of disparate healthcare applications. Iguana provides a flexible, patented scripting environment that we call the translator, which allows you to write scripts that move data from point A to point B. And this also allows for common libraries of functions and workflows to be easily updated and maintained. And the last point is that common, complicated, and unique workflows are possible. And this last point is very important because in 20 years that we've been around as a company, we've seen many different workflows that have required custom work to implement. And for a lot of our customers, they've rarely ever had to think twice about whether or not they can quickly implement a custom interface. And this flexibility was crucial during the height of the pandemic, especially when many systems had to be quickly updated. So with all that said, we're going to look at some of the success stories and the use cases that we had seen in the past 6 months or so since March, and the kind of challenges that a lot of our customers have been able to face. I've broken these down into 3 cases. So this is going to start from the simplest to the most complicated case. Now, the first case is the simplest and the most obvious one. So existing interfaces have had to be updated to accommodate for COVID-19. And one of our customers, actually Teletracking, for example, they used Iguana to gather data that's needed to track patient status and patient flow throughout a hospital. So they essentially utilize Iguana as kind of an adapter to gather the data that they need to do their work in tracking patient status and patient flow throughout the hospital. And at a very high level, it looks something like this. So the hospital EMR sends HL7 data to Iguana. Iguana normalizes the data, and then it sends that data either to a database or to another application that's managed by Teletracking, which then takes that normalized data and then does its work. Now, this particular pattern is definitely the most common one that a lot of our customers utilize. So in this case, I kind of mentioned Teletracking, but a lot of our customers have had this very the exact same workflow for their needs. And even though this diagram looks very simple, in a way it's actually not. Because as we all know from working with HL7, even though HL7 is supposed to be a standard, its implementation is anything but standard. There's always going to be differences and things that are non-standard when you work with interfaces in HL7. And there's actually a running joke that I've heard in many different contexts based on the saying that if you've seen one, you've seen them all. And for EMRs, if you've seen one EMR, you've seen one EMR. So that's really where a lot of the challenges come from. And the fact that many systems are very different, this is where a lot of the challenges really arise. But for many of our customers, existing interfaces were easily updated to include new code sets. So it wasn't really a problem for them in this case. So for example, additional code sets were added to indicate which patients had COVID-19 symptoms. And it was a very easy thing to do that was done in a matter of hours. And just to help visualize what I meant when I said that Iguana had provided a kind of like a scripting environment for integration, you can see here on the right, there's a condensed view of what the Iguana translator looks like. And you can see on lines 9 to 12, kind of what the basic mapping looks like. So, it's very easy to update the code mapping sets in this case and just, change the code slightly to accommodate for whatever changes that you had. Now, so this actually really isn't anything new. As I'm sure many of you know, when you work with HL7 interfaces, they always need to be changed or updated and tested at some point. But what was really different this time, especially during the pandemic, was that all of this had to be done very quickly. And this was because of how quickly the situation surrounding the pandemic was changing. Usually within healthcare IT, again, as we all know, working in healthcare IT, changes can happen very slowly. Sometimes even like a very simple change can take months to do. But with that pandemic, everyone had to shorten their timelines to days. And fortunately for all of our customers, in fact, all of the work that they need to do, they're able to do, again, on the order of days as opposed to weeks and months. So that was the first case. That was the most simplest case. The next case was slightly more complicated than the first one, and this one involves actually developing new lab interfaces. So in this case, one of our customers they're actually a large cancer research center. They actually need to develop a new lab interface for doing COVID-19 testing. And what was really unique about this interface was that a lot of the systems that they were interacting with were very, very old. And a lot of the messages that were coming out of these systems were very non-standard HL7. So this interface actually required complicated routing and message splitting because of the fact that these systems that were being interfaced with were very old and non-standard HL7 order and results messages were produced. So it looked something like this. So it required complicated routing and message splitting, and it was a one-to-many design. And again, this interface is very common, but again, the difference this time during the pandemic was that this had to be implemented very fast, on the order of weeks instead of months. And from the beginning to end, for this particular example, we were able to scope out the interface and develop it, test it, all of the testing that comes with developing a new interface, and deploy it within a month. And especially for this organization, that was an extremely, extremely fast timeline. Now, the last use case or the last success story that we have is also the most complicated one, and it actually involves developing a new infrastructure workflow. For this customer, they're actually bioreference laboratories. They do COVID-19, I believe, on the state level. And prior to the pandemic, their infrastructure consisted of several internal APIs that they had, which were used by internal clients for moving demographic and lab data around their internal network. And prior to the pandemic, this had worked just fine. There were no issues with this infrastructure at all. But with the pandemic escalating, what ended up happening was that the fact that everything was behind an internal, within an internal network, it started to become a bottleneck for COVID-19 testing. And so they realized, this is kind of like what their infrastructure looked like previously. Everything was behind essentially a firewall and contained within an internal network. And there was a greater need for external clients to be able to communicate with these internal APIs. So essentially, they wanted to expose these internal APIs to the world so that external clients could then make these requests and move demographic and lab data around. The problem with doing this was that doing this would actually directly expose their APIs to the world, and this would pose several security risks. So what they did was they wanted to utilize Iguana to act as an API gateway to handle the security. And the way that it worked would be that external clients would make API requests to Iguana. Iguana would then take that request, perform whatever authentication was required. So in this case, it was OAuth 2 authentication. And then it would then route the request to the appropriate internal API. So in this way, it protected their internal APIs by not directly exposing them to the outside world, but it still allowed requests from external clients to be made to their internal APIs. And this was able to bring down their testing results or their testing time by a significant amount. And what's really amazing about this was that this was a significant change in their infrastructure workflow. And again, the key point here was that this was achieved at a very short timeline. We had the initial conversations with them around the beginning of April. And this interface was developed and deployed by May. So in the software development world, that is extremely, extremely fast. So those three stories that I had just gone over were kind of like a summation or a summary of what we had seen in the past 6 months since the pandemic had started, from our perspective as an integration company. At this point, I would like to talk a little bit about what our role looks like going forward. Again, not just our role, but the role of the HL7 community as a whole as well. And since the beginning of the pandemic, we have been in and are still currently in unprecedented territory. So a lot of this is very new to us. We're still learning, all of us, we're still learning and figuring new things out, especially from a technology point of view. And as we've all seen, as we continue to approach new challenges, there are a lot of stresses on the systems. And these are things that we have not seen even within our 20 years as a company working in healthcare IT. But really the main takeaway that we got from all of this was that having rapid and flexible implementation when it comes to interoperability is key in adapting to a lot of these challenges. So again, a lot of the cases that we had gone over previously, they're not particularly new. A lot of them are things that we've all seen before, but the main difference here was that these things had to be done in a very short timeline. So with the pandemic, especially in March, the situation was changing by the day and new things had to be changed and updated by the day as opposed to by the month, as some people might be used to. And for us as a company, the best thing that we can do, and again, not just as a company, but also the HL7 community in general, is for us to support our customers, being on the forefront of supporting our customers for their integration needs. And as a HL7 community, I think we need to also make it as easy as possible for everyone to be able to communicate crucial data in a way that allows for quick and easy access to whatever information is needed by providers to researchers so that they can do the job that they need to do without having to wrestle with the data format, without having to worry about the format it's in and whether or not they can gather that data. And I think that in a nutshell is what HL7 strives to achieve, and also what we as a company are a part of and try to work on. So at this point in time, I would, again, truly like to thank everyone for making the time to join this presentation and sticking around to the end. As promised, we do have a contest where you can win, I believe it's, yes, 1 of 5 Amazon gift cards. So just follow that link below, and there are some instructions for you at the end. And you can enter yourself to win 1 of 5 Amazon gift cards. So I'll leave the slide up, but the next slide that we have is going to be the Q&A. So we are going to open it up for the Q&A part of this presentation. My colleague Prashant will help to facilitate that.
Thanks, Paul. We do have one question in the session Q&A on Whova. And if any one of you do have any questions for Paul, please do feel free to ask it over there. This question is, what is your experience with tracking lab results when the vast majority of older systems have linkage issues to the same CPT, let alone LOINC, L-O-I-N-C code?
Whoever had asked that question, are they on the Zoom meeting by any chance?
Yes, I am.
Okay.
My issue was trying to consolidate across a population like who had been tested for COVID-19, yet many reference labs were changing. When you're trying to do that kind of reporting or calling, you know, there were like 20 lab tests, then there were with the names that were COVID related, then there were 25, then there were 50. And then some organizations map them to different CPT codes, procedure codes. Some of them, let alone using LOINC codes to clearly identify how many tests. When you were trying, the main question is when you're trying to assess a population on who has been tested for COVID and whether it's positive or negative, the test names were constantly changing, and therefore your data to query from was inconsistent. You know, if you were only pulling and looking for test names that were the first 20 and then 5 got added, or laboratories, commercial labs were adding things, there were real problems in terms of building something that would consistently, you know, and getting all the players to agree on standardizing to the same CPT code or the same set of LOINC codes. Do you see what I'm saying?
Yeah, and this was across hospitals and across institutions, right?
Yes, this was across multi-hospitals.
Mm-hmm.
And you're trying to get, you know, for a population, say in the Southeast, you wanted to know exactly how many people had been tested positive for COVID. And if you weren't pulling the right lab test names, you had problems. So did you work on, when you were doing these queries to laboratory interfaces, were you working on pulling data by lab test name, by CPT code, by LOINC? How were you doing that? That's what part of my question.
Mm-hmm. So I don't remember the full details for a lot of these. So a lot of the lab interfaces that we had done, there were mappings and certain code mappings that were in place for certain fields that indicated whether or not, you know, the order of the results had any indications of COVID-19. This was within an institution. So within that institution, you know, they did have their own like self-consistent set of code mappings. In terms of solving this problem across multiple institutions, I think that would be a matter of having individual sets of code maps or individual checks in place for each institution and having to maintain each and every individual one across each institution. But I can't particularly speak on how we would have solved that problem if we had come across it. But I think within the institution, it was fairly easy, again, because we were able to quickly maintain or quickly update these code mapping sets. A lot of those problems we did not come across.
So did you do the mapping updates, or did another part of the institution do that for you?
It was provided by another part of the institution. So we provide the interface, you know, the infrastructure in place for doing the mappings, and then they would maintain that data.
Thank you.
At this moment, that's the only question we have right now. So I guess we could always ask people to sign up for the contest. Once again, it takes less than 10 seconds. Our newsletter will be coming out in the following weeks with a lot of great HL7 content. and here's your chance to win one of 5 Amazon gift cards. Paul, you could close it out here if you have any final words.
So we did questions. No, I just want to thank everyone again for taking the time to sit through this. I know it's pretty hard. It's a very different setting to have I guess look at a presentation online. Obviously we would prefer to be in person, in a room, but again, I do appreciate everyone for making that time to join this presentation.